Okay, Bulavinaka, and welcome to another webinar. I'm Dr. Lipate, and I'll be introducing our topic for discussion today. Our presentation coming all the way from the beautiful Fiji Islands, and our presenter, Dr. John Kelly, will be sharing some of the lessons that he's learnt from the Marshall Islands. So just to note that this webinar is being recorded, and a link will be available in the next 24 hours. I believe we're also going live on Facebook. So to those of you watching in on social media, Bulavinaka, and it's good to have you here at the webinar today. So we're currently launching the South Pacific Society for Lifestyle Medicine, and SPSLM is an organization that's dedicated to bringing together individuals and organizations to actively combat the pandemic that we are currently experiencing here in the Pacific of non-communicable diseases. And it's SPSLM is trying to promote the education and training of health professionals and the use of the latest evidence-based approaches to address the root causes of these non-communicable diseases. So lifestyle medicine, what is lifestyle medicine? So in essence, it's an evidence-based medical specialty that uses lifestyle therapeutic approaches, predominantly whole food, plant-based, regular physical activity, adequate sleep, stress management, and the avoidance of risky substances and other non-drug modalities to prevent, treat, and oftentimes reverse non-communicable diseases, sometimes referred to as degenerative chronic diseases. So that's basically lifestyle medicine in a nutshell. We also have the inaugural conference of the South Pacific Society of Lifestyle Medicine, and it's in the beautiful Pacific Harbor, which is on the island of Viti Levu, the main island in Fiji. And the resort is actually a 4-star resort, and it's smack bang in the middle of Fiji's adventure capital. So it's going to be a very exciting conference, and you'll want to attend this, and the date that you need to mark in your calendars is from the 10th to the 12th of March, 2020. So that's when we will have the inaugural South Pacific Society of Lifestyle Medicine Conference. So feel free to contact us for any information of this conference, and we'll be sharing information and the program in due time. Along with the conference, we will also be offering the International Board of Lifestyle Medicine Certification Examinations. This is going to be the first time that it's being held in the South Pacific, and this will be held on Friday after the conference at the Pearl Resort South Pacific, in Pacific Harbor. And if you want more information about this, you can feel free to email us at info@spslm.org, and we'll be happy to, like we said, share more information about the exams as well as the conference. Now, basically, the exam is one that is certified by the Lifestyle Medicine College in American College of Lifestyle Medicine, and you can do the review course, and at the end of the course, you sit the exams, like I mentioned earlier, at the conference. So you can do the exams in your various countries. Sorry, not the exams, the course. You do the 30-hour course in the various countries, and you can sit the exams when you come to beautiful Fiji in 2020. So we'll see you there. And again, for more information, your email is info@spslm.org. So I take this opportunity to introduce our guest speaker, Dr. John Kelly. Dr. Kelly has completed the dual degree program at Loma Linda University, and he received his MD and MPH in epidemiology with honors. He completed residency training in preventative medicine and received the American Board of Preventative Medicine Board certification in 2004. Dr. Kelly served as founding president of the American College of Lifestyle Medicine and also received the AMA Excellence Award, Excellence in Medicine Award in 2004 for his work in establishing the American College of Lifestyle Medicine. Dr. Kelly accepted an appointment as the assistant research professor in the nutrition department at Loma Linda University, and with the Lifestyle Research Initiative, where he conducted a multi-center outcome analysis of lifestyle centers in the United States. He also served as the co-primary investigator for a multi-million-dollar diabetes research project in the Marshall Islands. And he is presently director of the Medical Education and Research at Black Hills Lifestyle Medicine Institute. Ladies and gentlemen, we will officially hand over the presentation to our guest speaker, Dr. John Kelly. Buliminaka, Dr. John.
Okay, thank you very much. I want to just get my slides up here. Thank you for that very kind introduction. So we're going to talk today about the work in the Marshall Islands that you mentioned. It was a multi-million-dollar federally funded randomized trial done in Majuro, basically from 2006 through 2008, early part of 2009. I had the privilege of being the co-principal investigator, and then after the project was going, I asked to be just a co-investigator, not the principal investigator. Jamie Spence was the principal investigator after that. Now, just a little background about why this study was done and why the U.S. government was willing to spend $2 million there. Here's a little graphic from showing the globe and the spread of obesity. And if you notice, the darkest color of orange-red there is at the bottom right. You can see it's greater than 60% of the population in a given nation or continent that were overweight or obese. And if you're up to date on the latest trends, actually the obese and morbidly obese are faster growing in the globe now even than the overweight category. So this is a snapshot I took from the hotel where I stayed typically when we were over there. Beautiful picture of Majuro on the bay side, not the ocean. So let's just give a little background about type 2 diabetes in the Marshall Islands. In the 1950s, right after World War II, the U.S. Defense Department, I believe it was, did a survey of the Pacific Islands and their health status and so forth. And there were 3 persons in all of the Marshalls that were had diagnosed type 2 diabetes. But in 2002, a large survey was done by Mrs. Alfred. It's there, a citation at the bottom, an unpublished step data that was presented in 2007. They found in a survey of about 3,000 individuals, they found the average fasting blood sugar was right at the pre-diabetes level, 110 milligrams per deciliter. And a significant portion of the juvenile population had fasting blood sugars in the diabetic range. So actually type 2 diabetes is the #1 health concern of the Republic of the Marshall Islands. The prevalence, and this number, 30% and growing, over 30% and growing, was current in 2009. I'm not up to date in the last decade. The goal, of course, of this project was to arrest or even reverse or turn that tide back. I need to say that at the time that we did the research, the age at onset of diabetes was dropping and new cases were being diagnosed in their teens. This little graphic will illustrate why this is such a problem. This is taken from Diabetes Care, published in 2003, and it was the current at the time that we did this research project. And what we're going to look at here is the effects of the type 2 diabetes on MI, myocardial infarction or heart attack, and the darker one will be stroke. And what we see is when we using non-diabetic as a relative risk of 1, so that's the risk of heart attack in a non-diabetic is shown on the left. When we look at the diabetics who had an onset of diabetes over 45 years of age, what we might have used to have called adult onset, we see that the risk of heart attack is 3.7 times the person that's a non-diabetic. And in the US, we know that heart disease is the leading cause of death. So we're talking here that the non-diabetic is primary cause of death in the US is heart attack. But if you have diabetes start over age 45 years of age, you have 3.7 times that risk. But look what happens over on the far right. This is where the onset of diabetes is under 45 years of age. And this risk then climbs to 14 in this particular study that was published in 2003. But when we look at stroke, the numbers are just devastating. We see that the risk of stroke is approximately the same as it is for heart attack if the onset of diabetes is over age 45. But if it's under age 45, it goes up to as high as 30 times the risk of a non-diabetic. So this is why diabetes is just a tsunami of cost and care consuming resources, and why the Marshall Islands really needed to do something about this. So it turns out that treating the complications of diabetes, we were just looking at heart attack and stroke as two illustrations, but there are many others, as you know, infection and amputation, etc. These are really consuming the resources of the Ministry of Health, which does not have unlimited resources, but in fact, I saw a statistic that when we were there in 2007-8, the 80% of the admissions to the hospital in Maseru were connected with type 2 diabetes, were connected with complications of diabetes. And so just consuming the resources of the Ministry of Health and really undermining the ability to focus on prevention and get ahead of this epidemic. So what we did was called the Diabetes Wellness Project. It was a project of the Marshall Islands and Canvasback Missions, who has been providing a lot of care, medical care in Micronesia for many decades. The pictures here just are taken of staff at the Wellness Center. On the left is Dr. Wes Youngberg, who helped us get started with the project, and he was taking blood sugars on one of the patients, finger stick blood sugar. Across on the top right is a picture from the kitchen. I call the kitchen the compounding pharmacy for lifestyle medicine, because if you're going to make lifestyle changes in diet that will change gene switches, it truly is a compounding pharmacy. A notable lady in the picture there is Brenda Davis. She's the redheaded one. And then down at the bottom, we see a picture taken from the exercise testing room. We did have some equipment there, but we were not promoting machines as the preferred form of exercise, because that would be quite limiting. We actually encouraged and taught our subjects to walk as the primary form of exercise, but we did use the machinery for doing fitness testing and so forth. So let me just give a little brief history about the Marshall Islands. Apologies to anyone who's from Marshall Islands and knows this better than I do, but many of us weren't aware of this. But after World War II, the U.S. relocated the inhabitants of Bikini Island because they wanted to conduct some atomic bomb testing. And unfortunately, thousands of individuals ended up getting exposed to radiation because of the downwind and the amount of, and how the distance that the radiation traveled. And some people actually received lethal doses and died from it, but many more were actually subject to sublethal doses. And I personally feel it was the appropriate thing that they approved. Eventually, the U.S. government did approve reparations and have spent millions of dollars trying to help the Marshall Islanders for this terrible thing that happened. Well, one of the results of this is that the Marshallese have been affected, like many other people groups, when a lot of money, entitlement comes along. And so many of the Marshallese tend to view whatever health problem they have in the context of that radiation exposure. And it's understandable, but it's not always reasonable. And many actually we ran into in the Marshall Islands either thought or wondered if their diabetes wasn't somehow the result of that radiation exposure. And there's one sense in which I agreed with the health ministry's department, and we were talking about this, is that actually the reparation monies in many ways did harm the tropical lifestyle that the Marshallese had, and that indirectly, I do believe, made their diabetes epidemic worse. So the non-government organization, Canvasback Missions, as I mentioned earlier, had been doing medical services in the Marshall Islands for many years, and they had been working with type 2 diabetics for over 20 years. Those numbers are updated as of now, as of today's date. So they've been working with type 2 diabetics for over 2 decades. The history of the lifestyle interventions that Canvasback did really go back to 1996 and 98, when they conducted 2 successful lifestyle intervention programs in the Marshall Islands. They used staff from the Weimar Institute in the United States and from Guam SDA Clinic Wellness Center, and they used what was basically called a New Start program, and it's very similar to a CHIP program. They had really fantastic outcomes. While there was not a study published, in a peer-reviewed journal, they did keep track of the labs and the changes, and it was quite successful. Medication dosing was reduced or stopped in some patients, and blood sugars were definitely improved. So the Ministry of Health then in Marshall Islands really encouraged Canvasback to do more of these programs and to find a way to make them more widely available. So eventually Canvasback, Jamie and Jackie Spence were able to secure funding from the US government to study, and the government wanted it done as a study, not just as a program. And actually I think that was wise. I think it was smart to do this in a very systematic way and track the results. So in building the protocol for the program, so finally there was funding, there was the preliminary pilot programs, but now we needed to have a scientific a basis for what we were doing. And so here's one of the illustrations from Diabetes Care 2006, Neil Barnard and his team, and they were looking at the use of a plant diet and its effect on diabetes and glucose in people with type 2 diabetes. It was a randomized trial, and it compared a low-fat vegan diet to the American Diabetes Association diet and its effect on blood sugars in type 2 diabetics. They published the 22-week results in this particular article. So 49 of these diabetic patients were assigned to the experimental group, which was basically a 10% fat, 15% protein, 75% carbohydrate diet of vegetables, fruits, grains, beans, legumes, etc. And the control group was 50 that were assigned to the Yeah, the American Diabetes Association diet. So that was the control. That diet was typically a 15 to 20% protein, less than 7% saturated fat, 60 to 70% carbohydrate, and monounsaturated fatty acids with a cholesterol intake of less than 200 milligrams a day. This is, if you're familiar with this, this is similar to the American Heart Association Step 1 diet in some ways. So the results then show here in this graphic, this was the blue line in the graph is the plant diet, a low-fat vegan diet. The red lines are the American Diabetes Association diet. The key thing to understand here that's a value is there's two blue lines and two red lines. The reason is that they were published the results. They stratified the results by individuals that were medication stable during the study and those who had medication changes. So the ones that were medication stable have the solid, I think I have a line here, yeah, the solid center. So the solid square red line, that's the control group that had no medication changes. The solid blue circle, that's the lowest, the bottom line here, and that's the experimental group that had no medication changes. And if you think about it, medication adjustments in general attenuate the effect of lifestyle, because if you put a medication on board, on the controls, it tends to lower their blood sugars, which tends to bias toward the null of no effect. And on the other hand, if you have people in the experimental group who come off of medications, it tends to, again, attenuate the effect and bias toward the null. So the stratifying the results as they did was an excellent an analytical approach. Here's this graph was published in the American Journal of Clinical Nutrition in 2009, and this showed actually 74-week. So the first 3 measurement points were shown in the previous graph, but then they tracked these individuals over time. And what we see here is very typical of lifestyle intervention, and that is there's a immediate and strong improvement in the first few weeks, and then over time there's recidivism and regression as it's difficult to maintain lifestyle. But what is very relevant here and highly significant is if we look at the effect of the conventional American Diabetes Association diet, it's obvious that the plant diet group never reached that same level. They were had better results and more better A1C numbers for up to, this is about a year and a half, 74 weeks. I wanted to show that compared to another study I did later, and this was a study using a CHIP program for 4 weeks, and it was done in a medical setting in Roanoke, Virginia. And here's what we see, that and this was again type 2 diabetics in a lifestyle intervention program, and they had a 43 milligram per deciliter drop in those 4 weeks. That was a 26% drop in fasting blood sugar. And this was absolutely amazing to the physicians and the nurses that were, taking care of these patients. We came in and did an intervention program in their medical offices in the evenings, like I say, for 4 nights a week for 4 weeks. You can see the cholesterol also dropped 14%, triglycerides 30%. And in fact, this was so dramatic an effect that both doctors that were co-investigators on this study later went and used their CME time to become CHIP facilitators so they could conduct CHIP programs themselves, and also a couple of the nurses did the same thing. So This, let's go a little bit of the details about the study. So we randomized about 150 diabetics. I think the actual number is close to 160. The hemoglobin A1C, so the inclusion criteria for the study were that the subjects had to have an A1C of greater than 8, or they had to have diagnosed type 2 diabetes on medication. And we randomized these subjects for 6 months to one of two groups. The first group received a comprehensive lifestyle change program. It was again based on similar to a CHIP program. It was based on a New Start program. We actually adapted what was being done in the Guam SDA clinic, and we made it, tried to make it culturally sensitive to the subjects there in Marshall Islands. And it was a low cholesterol, high fiber, plant-based diet. And we say low cholesterol because this was not a vegan diet like was tested by Barnard. There were fish and non-plant food items in the diet that were, and we'll get to that in a minute. It also included exercise as a part of the intervention. The other group were getting optimized usual care. Basically, what we did was we took the results from their screening test, and when we had the blood test at the beginning, and we would refer them to the Ministry of Healing clinic where they could decide, if they, so we didn't dictate to the diabetes clinic over there at the hospital what to do, but we sent the results with the patients, and many of them, of course, did receive some kind of treatment during the control period. So their medications might have been adjusted or increased or whatever. We also provided pedometers for them, and that's why another reason this is sort of optimized usual care. It wasn't just the standard care that was being received by the average diabetic in Majuro, because we were trying to track their activity. So we were giving them pedometers, and there's definitely research showing that just giving a patient or a person a pedometer and tracking it is a form of intervention. People actually walk more when we're measuring our steps than when we're not. We also did some PBSM, it stands for personal blood sugar monitoring. So we used some glucometers in some of the controls on some cohorts. We'll look at that a little bit later. There wasn't any observable difference in the controls that had glucometers and didn't. This is a picture of that first group. I would point, I don't know if I can show my pointer here, it's not showing up, but over on the right-hand side, the lady there with the apron on was Mrs. Langwardick. She was the Minister of Health at the time, and she wasn't diabetic, but she participated along with the mayor of Majuro, happens to be the guy in the middle with the boxing gloves on. We were just horsing around there. You can see him horsing out, but he also participated, trying to build support and for it. So this is the treatment schedule. This is here. The top table 1 is showing the week. I'll just take this. Oops, I'm sorry. It's showing the week. So the first 2 weeks, the frequency was daily. We had 4.5 hours of group session plus an hour of exercise and 3 prepared meals. We fed them breakfast, lunch, and supper. Some of them that couldn't come at the lunch hour, we sent a take-home or take-out lunch with them. Weeks 3, 4, 5, and 6, the next 4 weeks, we met twice a week, and it was a 2-hour group sessions with exercise and a prepared meal. So it was after work basically. And then the next 6 weeks, 7 through 12, we met once a week in a 2-hour session. And then the last 3 months, we met twice a month or every 2 weeks. And this was the initial configuration. This is how we did the first couple of interventions. Now looking down at the bottom of this slide, you can see here a graphic flow of the subjects in the study. So if the A1C was greater than 8, then they would be randomized into 2 groups. You could see the 0 baseline, then 2 weeks, 6, 12, and 24 weeks is when we took measures. The treatment group there is shown, and it is on the top, and we tried to do follow-up. The follow-up was not very successful. It was hard to get people to come back after their treatment was over, but we did get some follow-up on them. The control group, then you can see that group was to basically delay their treatment. They were eligible to take the treatment, but they promised that they would make no changes for the 24 weeks. And you can see then the dotted line going down at an angle to the next treatment group. So when there was a subsequent treatment group, after the controls had finished serving as controls, they were allowed to join a treatment group and experience the treatment itself. So this is a much more busy looking chart. Let me just take this one step at a time. It's actually not that hard to understand. So up at the top, we have the timeline. We have year 1 and year 2 of the study. There was 2 years of research that were funded, $1 million each year, a portion of which went to the oversight organization in the US. Then there you can see the cohorts. So in the first year 1, there was 1, 2, and part of 3 that overlapped year 1 and 2, and then 4, 5, 6, and 7. So, but the first 5 cohorts are the ones that constituted the randomized trial. The 6 and 7, if you look at the recruiting source here, the 6 and 7 cohorts only were done so that the crossovers from cohort 4 and cohort 5, the controls, could have experienced the treatment. And dropping down to language, you can see we did different things. The first 3 cohorts were conducted in English, and we tried to recruit during those cohorts individuals that had could understand English, and overall, I mean, the way that sounded, I don't mean to say that the Marshallese can't understand English, but we were looking particularly at that as one of the criteria, knowing that we were going to be working strictly in English to start. Later, we would that became less of a criteria, and people who wanted to join the study but didn't understand English, we enrolled them later in cohort 4. We had English translated to Marshallese, and then we had in cohort 5, 6, and 7, we had it actually presented in Marshallese by Marshallese staff. You can see the start and finish dates of each cohort are there. And then the line just below where it says groups, you know, the groups are numbered very simply: intervention group 1 and control group 1 and so forth across. But then in the glucometer, we had some, you can see we had, for the glucometers were used for the treatment group, that Diabetes Wellness Center, but not for the control group for the first 3 cohorts. But then in year 2, and this is one of the changes that was made in the second year, we did do things a little differently in the second year. And one of the things was we did provide glucometers for some of the controls to see if there was any, because the thought was in the first year that, well, that may not be a fair comparison to say that the changes are all due to the lifestyle intervention if we're doing glucometer readings on the treatment group but not the control group. Because again, like wearing a pedometer and recording it, it's been shown that diabetics who measure their glucose with a glucometer, it does improve the reading. So anyway, so that's why we did do some where we actually gave glucometers to the control group. we were unable to show that there was any significant change and from the controls in those cohorts and the earlier ones. There was just a little too much noise and variance, and we were unable to show anything statistically significant. I'm not going to go into more detail on this unless there's a question period and we want to do that at another point. So basically we were using a predominantly plant diet to treat the diabetes there in the Marshall Islands. And again, this is the picture of the compounding pharmacy where we were preparing that diet. You can see Brenda had a number of helpers who were all Marshallese ladies, and some really fine cooks and fun people to work with. It was a great team. So we were using, things that were available in the as much as possible. There in the Marshall Islands, we were cognizant of the fact that food that's shipped in can be prohibitively costly. But there was one of the nice things was there was a farm center or a farm project down at the far end of the island where there was a little more soil, and we actually started getting produce from the farm there as used in the kitchen. While I'm thinking about that, we also taught them to use grow boxes, and we started introducing grow boxes which are like, I don't know, 5 feet long by a foot wide, and you could grow vegetables and we grew tomatoes, a number of different things in these grow boxes to encourage people to grow and eat vegetables. So we used a system that I appreciate. It was a collective thing, but to a large extent, Brenda Davis was one of the main engineer, I think, on this system. And that was we classified foods into 4 categories: first class, second class, third class, and fourth class. We explained it to our participants in simple terms, saying, well, because they, as you know, in the islands, you do a lot of flying, and we tell them, well, we want to bump you up to first class any chance we can. And so basically what we had was in first class vegetables, fruits, nuts, whole grains, legumes, and seeds. Those we considered to be the first class of foods for treating diabetes. And the second then was fish, lightly processed whole grains, tofu there, canned vegetables and fruits, salted nuts and seeds. And then third class, and the way we did is we said we want to eat as many first class as possible, second class, some, third, rarely, and fourth, we really want to avoid. But, and you can see we had meat and poultry in the third class, fried vegetables. Again, we had research on each one of these things. We know that the more processed and the more animal foods and the way the food is prepared, all of these things make it more difficult to control or reverse diabetes. And the fourth class, processed meat, high fat meats, refined carbohydrates, and so on, fried, salty snacks and foods with hydrogenated fats. So this was a system that we found the subjects were able to understand and relate to and use. So again, this how we were teaching them. We were explaining to them that the first class foods really have the best protectors, the most active things to change the gene switches in a favorable way and to control type 2 diabetes and insulin resistance. And that was, as I mentioned, this is the ones that we would encourage them to eat primarily, mostly, and there's, again, the examples. The second class, we said these are foods that can be included, but again, these should be eaten in moderation. So, and you can see examples there, the whole grain breads and cereals, fish, and so forth. As it says, these foods, we taught them, were less potent sources of protectors. So they were generally not harmful, but their benefit was much lower. So again, it was healthy foods, but better to eat the first class. Third class, these were foods that actually had definitely harmful fats. They had harmful things. These should be eaten sparingly, if at all. And it says, we explained, these are low in fiber, and there's no fiber, of course, in animal foods, and or they were fried. Even virgin oils, they have harmful effects. Then the fourth class, these are the ones that contributed most really strongly to development and progression of the type 2 diabetes. And the instruction was to seldom, if ever, eat these foods. And again, discuss this, that they have harmful components and they're low in fiber and have they actually work against the antioxidants. They are oxidants. We also included exercise in the intervention program. We taught them to do exercise by walking and by doing calisthenics, dance. There was some recreational dance that was included for the ladies in particular. Here again, I was talking about this for the fitness measuring. I think I have a number here. Yes, Keanu Lalamo, he was actually a diabetic. He was also a nurse, and as was his wife, a nurse, and they were both diabetics. And they wanted to be in the study, but he met the criteria, the inclusion criteria, but interestingly enough, he also met the exclusion criteria, meaning he had serious peripheral arterial disease and could not walk, but short distance without pain and having to stop. And the study criteria protocol required that someone with those conditions had to have clearance from a doctor. And I'm not surprised that the doctor was not willing to give him a clearance to be in the study. However, his wife qualified and she was in the study, and we had a policy that you could accompany, your spouse could accompany you. And so he wasn't technically in the study, but he was there. And so I made sure that I walked with him every time for the first week that we went walking, because he would definitely stop and he would be in pain, and I would visit with him and distract him and watch to make sure that something serious wasn't happening. What he really had was not that unsafe. He had stable coronary artery disease with peripheral arterial disease. And so it wasn't serious. It wasn't, acutely dangerous, but it was certainly something I was more comfortable being beside him. What was interesting is it says here is after 6 weeks, he was walking without pain, but actually he began to walk without stopping and walking through the pain after 2 weeks. And he told me I didn't need to go with him anymore. And when he was no longer stopping, I actually did stop walking with him. But by the end of 6 weeks, he had no more pain at all with walking. So here's the results from the first cohort, the first 10 days. This is the average finger stick readings from the morning. There's actually 3 different columns here. You can see the legend. The morning fasting, then we would do morning exercise, take it again, and then and after the evening meal. And so there's 3 numbers across there. When you look at the regression equation, and you can see there's a pretty good straight line effect here. There was a 74 milligram per deciliter drop average. Some of the patients dropped considerably more than that, and of course some less, but an amazing drop in 10 days. I've had, when I've presented these results at some medical conferences, I've actually had diabetologists come up and say, well, what did you do? Did y'all put insulin pumps, or how did you get that kind of a drop? And I said, the 2 patients in this cohort that are on insulin, we had to stop it because lifestyle is more powerful treatment for diabetes than insulin. So I'm just showing you, I'm not going to go into it, but we did have some preliminary data that showed drop in fasting blood sugar, improvements in the HOMA-IR. We calculated the homeostasis model of assessment insulin resistance, and definitely found decreases there. The A1C also. But here's probably the best overall graph I have. And this shows the intervention group at the bottom with the diamond, and the control group on top with the square. And you can see the week out to 24 weeks at the bottom. There's actually the numbers are shown in the table. And what we see here is that the control group had an improvement as well as the intervention group, but not as dramatic an improvement. And the other thing we see is that both groups tended to, just like in the study we looked at from Bernard, tends to incline back up towards baseline values, although they did not reach the same level as they started at, which is a good thing. Unfortunately, we don't have much data beyond the 6 months, 24 weeks. But I want to show you something very interesting that we observed clearly in the data. When we stratified the data, we saw that this section of it here was there was quite a diversion, quite a separation. And what we saw was that if we looked at the, so here I'm just showing the intervention group that's still in the diamond shape, but I'm showing the two different groups of them. And those that were adherent were here in the lower section, and that line showed about somewhere in the neighborhood of a third of the subjects in the study would have continuing improvement. We had a number of individuals, like again, around 30 to 35%, that attained normal glycemia and without medications. However, we had a number of them who, about a similar number, about a third, that actually regressed and went pretty much back to their original numbers. And in our, subjective evaluation, we would talk to them about, how's it going, and get, in essence, feedback. What we discovered was that there were individuals that considered the lifestyle changes not suitable. They didn't want to do that, even though it helped their blood sugar. Just wasn't how they wanted to eat or live. And the others were people who were bound and determined. That they, I could tell stories about anecdotes. We would ask some of the ones that were really having tremendous results. What are you eating? How are you doing this? And one little illustration will suffice. But this one couple, both were school teachers. They told us, "Oh, we like oatmeal, so we have we eat oatmeal with whole fruit and seeds in the morning." Okay, and so when we asked them about lunch, well, we have oatmeal. So those people had largely moved from eating rice at every meal to eating oats or oatmeal at every meal, and the oats are much more effective for controlling blood sugar than the rice was. In fact, it turned out, to my amazement, that the particular type of rice that was being sold and consumed in Maseru was what's known in the U.S. as Calrose rice, and the brown Calrose rice has a glycemic index equivalent to table sugar. We were amazed, and so no wonder. I don't know exactly how that came to be, why that particular rice was the one that was so popular there, but it would have been hard to find a worse carbohydrate for diabetics to be eating. So I want to show you two illustrations, and this is from the kitchen. So you can see on the left there, side to the right, actually, of Brenda Davis is one of them, and one here to the. So I started at the wrong side. Yeah. So you can see now I've got the two individuals, the two ladies, that and what happened to their hemoglobin A1C in 12 weeks. So over on the left side, she went from 8.7 to 5.7. And on the right, she went from 11.5 to 8.3. By the way, she continued to come down, and that 8.3 did come into the normal range. So what were the conclusions that we had from our research? Basically, it was clear that that there's a lot of evidence that lifestyle change can slow, arrest, or reverse high blood sugars. And there was no one in any of the intervention groups, there was no one that did not have improvement during the intensive 2-week phase of the intervention. And some, as I say, had, well, the average was 74-point drop in that first group. The other thing that's really obvious was that the existing approach that's being used with type 2 diabetes in the Marshall Islands and elsewhere is not working. I mean, there was just basically rampant epidemic, and so it has to change. And what we now were able to show from our research was that intensive lifestyle changes can work, and if they're maintained over time, there's a dose-response relationship, and it can be very effective treatment for type 2 diabetes. And it's interesting, one of the more remarkable things that happened was what we call a spillover effect. The largest grocery store chain there, the Payless Supermarket in Majuro, wrote a letter there, and I have an image of it showing on the screen, but he basically says that he can no longer keep healthy foods on the shelves. He said that when we first started the project, that the problem he was having is that if he had healthy plant foods or vegetables on the in the store, he would have a lot of spoilage and a lot of loss. But after we had our first couple of cohorts, the people would come in and find out when is the shipment coming, and he says the food would be sold within 3 days. He couldn't keep it on the shelves. So it really was making a difference in the culture there. Obviously, we need to do more research, and Canvasback is continuing to conduct this and man this. The Diabetes Wellness Center has become, is still operational, continues to do programs. They've expanded where they're now offering healthy meals, sort of like a cafe or a restaurant. And Canvasback really is working to expand this and take it to more parts of Micronesia. I know before I left the project in 2009, there was a meeting of, and I took an amazing picture. There was, I think I had 9 first ladies from the Micronesia where they had all come to visit the Diabetes Wellness Center and see what was being done. And so there's quite an interest in what is happening there in Nigeria. So thank you. That's the end of my formal presentation. I am happy to take questions or to answer any questions or explain anything.
Yeah, thank you very much for that, Dr. Kelly. Dr. Kelly, one of the things that that we found when running programs like CHIP here in Fiji, it's a question that keeps coming up with every group, and I'm wondering whether you came across it in the Marshalls while you were working there, and it's the use of coconut milk, the raw scraped coconut, and you squeeze it. Yeah, and the use of that in foods, because we do know that it's got a bit of fat in there, but did you have any experiences with that in the Marshalls?
Yeah, thank you. That's a very interesting question, and I appreciate the value of it. Actually, what happened was we did encounter, of course, some individuals that used that, but when we were in the treatment program, the treatment intervention diet, that was, if I'm not mistaken, a class 3 food or class 2. It depended, actually. So it was not forbidden, but it wasn't part of our, we didn't serve it.
I see.
But definitely there were people who enjoyed that and liked that. What we taught in general was that the whole coconut was the ideal. There is to
Yep.
take the whole meat of the coconut and eat that, or maybe grind it up if you wanted to. But again, we taught them that the more processing you do before you eat it, the faster it's going to, change your blood sugar, etc. But I think coconut is one of the healthy native foods in Micronesia, and we certainly did not try to stop them from using it. We just wanted them to use it in its healthiest form.
I see. Okay. Yeah. So in essence, back to the concept of food as medicine. Eh?
Mm-hmm. That's right.
Interesting. Well, I think we thank you, Dr. Kelly, for your time, taking out the time to come and share with us that interesting experience from the Marshall Islands. And I know that some of you might have some burning questions, and would like to invite you again to just send that to us in an email, and we're happy to get Dr. Kelly to maybe reply to you back. But thanks again, ladies and gentlemen, for joining this webinar from wherever you are. And I noticed some people from Samoa as well, Talofa. And yeah, thank you for joining this. Please spread the word of lifestyle medicine, as this is the direction for the future in order to combat this surge of non-communicable diseases. We need to treat the cause. And the cause, as Dr. Kelly succinctly showed us, is the change in lifestyle that we've adopted here in the Pacific. So yeah, once again, till you hear from us again from the South Pacific Society of Lifestyle Medicine, Winaka Wakalevu, and Mother for the time being.
Well, thank you for having me.
Awesome. Okay, wait for Dr. Paul to come back.